Hello, my name is Alejandro Rabinstein, and I am a professor of neurology at Mayo Clinic. This is the webinar related to neuromuscular respiratory failure or acute neuromuscular diseases. I'm going to try to complement what we wrote in the chapter in order to give it a more practical take, since I have been doing this for longer than I want to admit. So, neuromuscular respiratory failure, although most of us in the neuro ICU think mostly of the brain, truth is that we need to know about how to recognize severe weakness from a neurological cause that can result in respiratory failure. And in order to do that, there are certain principles that are helpful. In addition to doing a comprehensive neurological examination, it is important when you are finding a patient with respiratory failure for whom the cause of the respiratory failure may be neuromuscular, you need to examine specifically certain aspects, certain elements on the examination. And first and foremost, you need to examine the diaphragm. And in order to examine the diaphragm, you lay the patient flat and you look at the breathing pattern. If you identify paradoxical breathing, that is a seesaw movement of the chest wall and the abdominal wall, where the abdominal comes in instead of going up with each inspiration, that is paradoxical breathing, and that represents diaphragmatic failure. In addition to that, you're going to see if the patient is using accessory muscles for inspiration or expiration, and you're going to pay a lot of attention to the bulbar weakness, because the effectiveness of the bulbar weakness, the strength of the effectiveness of the bulbar muscles, the strength of the bulbar musculature will determine whether the airway is safe, whether the patient may be at risk for aspiration because of failure of protective reflexes. In order to understand how neuromuscular respiratory failure progresses, it is useful to have some basic pathophysiological concepts well understood. As a patient goes into neuromuscular respiratory failure, the first thing that happens is that there is microatelectasis at the bases, and that leads to a mild degree of hypoxemia, which may not be noticeable enough to raise eyebrows, but it is sufficient to alert the experienced clinician that something is going wrong. Saturations in the mid-90s is what I'm talking about. That is the time when you want to intervene. The next thing that happens is tachypnea, and when tachypnea occurs and you check the ABGs and the pH is normal, or more importantly the PCO2 is normal despite the tachypnea, you know that the patient is not exchanging air at the pace that it should. If you are tachypneic, you should develop a respiratory alkalosis. So if your PCO2 is normal, that is actually abnormal and should be interpreted correctly. Because the next step is that the patient is going to start getting increasingly fatigued, and the hypercapnia will develop because of hypoventilation. And as hypoventilation sets in and the acidosis occurs, the process accelerates, and eventually the patient crashes with more severe hypoxemia, which is the final stage of neuromuscular respiratory failure, with a combined hypercapnic, hypoxemic respiratory failure patch. Neuromuscular respiratory failure can happen because of a variety of conditions, of which two that I'm going to be discussing in a couple of minutes are the most important because they are the most frequent: Guillain-Barre syndrome and myasthenic crisis. However, many other causes can happen, and what is important is to identify the cause, because we have found, and we published this a few years ago, that patients in whom the cause of the neuromuscular respiratory failure is not identified have a worse prognosis. Therefore, identifying the cause of the neuromuscular respiratory failure in order to be able to treat it adequately has an important prognostic implication in the short and longer term. The evaluation of a patient with neuromuscular respiratory failure should include a history and a physical examination. It should include evaluation of the ventilatory capacity of the muscles by the physical examination itself and by bedside respiratory muscle tests measuring the forced vital capacity, the maximal inspiratory pressure, also known as negative inspiratory force, and the maximal expiratory pressure. Should also include the chest X-ray and arterial blood gases. More recently, the advent of a good quality diaphragmatic ultrasound has become a nice complement to the evaluation. When bedside respiratory tests are not available, then the examination has to include certain tricks to try to gauge how sufficient the ventilatory muscles may be, and that may include, for example, asking the patient to count forward with a single breath and aloud. And if a patient can count from 1 to 20 on a single breath, in general that patient has enough vital capacity to maintain a spontaneous ventilation without immediate problems. Okay, so you take the history, do an examination, you check bedside respiratory tests, particularly useful for assessing the risk of respiratory failure in GBS. You check a chest X-ray to exclude atelectasis and pneumonia, and you check your arterial blood gases. And with all that information, you have to approximate the potential causes for the neuromuscular respiratory failure, acute neuromuscular weakness, at least in terms of developing a differential diagnosis. And you should also determine whether the patient needs to be admitted to the general wards or the ICU, and whether the patient needs ventilatory assistance, be it non-invasive or invasive. So many causes of acute neuromuscular weakness can end up in respiratory failure. As I said, GBS and myasthenic crisis are the two most common. It is not infrequent that you diagnose for the first time amyotrophic lateral sclerosis when the patient gets admitted to the hospital with respiratory failure, even when the condition was never suspected before. You rarely can have it with myopathies and other forms of neuropathies, but let me concentrate for the sake of time in the two major most common causes, Guillain-Barre syndrome and myasthenic crisis. Guillain-Barre syndrome may be associated with respiratory failure among hospitalized patients with this condition in 25-30% of cases, and the patients that end up with respiratory failure from Guillain-Barre syndrome are typically the patients that have rapid progression of the disease, and therefore it is important in these patients to act preemptively. Patients with Guillain-Barre syndrome, apart from having severe weakness involving ventilatory muscles and bulbar muscles, are also at risk of severe dysautonomia. And dysautonomia can cause complications in the setting of emergency intubation, and therefore it is important to intubate these patients with enough time, not in the setting of an emergency, to prevent complications. So when you think that a patient with Guillain-Barre syndrome, because of the severity of weakness, the rapidity of progression of the weakness, the results of the bedside respiratory tests, whenever any of these conditions tell you that the patient may need intubation in the short term, better to intubate them now. non-invasive ventilation is not a good option for patients with Guillain-Barre syndrome because these patients have a neuropathy, be it axonal or most commonly demyelinating. And once they reach their nadir, their maximal weakness, they are going to stay there for some time. And so you do not gain anything by putting them on non-invasive ventilation, because they are not going to be on non-invasive ventilation for several days, which is the minimum duration of time that they are going to be at that nadir. And on the other hand, you're risking the patient having to be intubated in an emergency situation, which I said, particularly because of the associated dysautonomia, can be dangerous. Patients with Guillain-Barre syndrome can have a number of other complications from dysautonomia, including ileus, hemodynamic instability, etc. They can have neuropathic pain. Their management exceeds the management of the respiratory failure, but in terms of the respiratory failure, it is important to recognize that in general they are going to require ventilatory assistance for quite some time, and therefore you should never rush to extubate a patient with Guillain-Barre syndrome. A good proportion of these patients are going to require tracheostomy, and that's fine. You have to reassure the patients that the ventilatory muscles will start working again, and eventually they'll come off the ventilatory assistance as time goes by. Myasthenic crisis is a different story because myasthenia, as you all know, is a neuromuscular failure of neuromuscular transmission that primarily is manifested in the form of fatigability. So if you can provide assistance to the respiratory muscles before they have failed dramatically, you may allow them to rest, and if they rest, they may become more functional again. That is where the use of non-invasive ventilation with BiPAP can be particularly useful. We have shown in a couple of papers that the timely use of non-invasive ventilation with the BiPAP mask can result in a change in the natural history of the myasthenic crisis. So if you start non-invasive ventilatory assistance, particularly before the patient has become hypercapnic, you may be able to treat the patient with non-invasive ventilation first continuously, then discontinuously for a few days without the patient ever having to be intubated. And if the patient has to be intubated because it has reached that point, then probably the patient is going to be intubated for 7, 10, 12 days. So it is a very useful strategy to consider patients with myasthenic exacerbation and crisis as potential candidates for early support with non-invasive ventilation, so you don't have to intubate them and they don't have to stay in the ICU for several days with all the secondary pulmonary complications that result from the intubation and invasive mechanical ventilation. So these are a number of clinical pearls for the management of neuromuscular respiratory failure in general, and some practical concepts for the ventilatory management of Guillain-Barre syndrome and myasthenic crisis that I hope you will find useful in your daily practice. Thank you very much.